start. My name is Anastasios Maniakas. I'm one of the head and neck surgeons at MD Anderson. I'm otolaryngology trained, head and neck fellowship, and after that was working in Montreal a bit, and then came back to join the wonderful team at MD Anderson. And it's been a pleasure being able to work amongst those colleagues, but also incredible to be able to treat the amazing population that comes and sees us as well. Both, straightforward, but also complex cases. We're very fortunate to be able to be in this institution and to treat a lot of the people that we see and a lot of people that we're seeing here as well. Okay, great. Some quick disclosures. This is mostly just contract and research contracts work that we have for a lot of the translational work that we work on in the lab. A lot of the mouse models work that we're trying to do to develop new drugs, new therapies for patients with aggressive thyroid cancer, ranging from well-differentiated all the way to anaplastic and medullary. This little disclosure, once again, very, very happy, very proud to be able to work with some amazing people. What you see here on the left-hand side is a big group of our MD Anderson endocrine surgery, both head and neck surgery and endocrine medical side as well, neoplasia. And on the right-hand side, that's our head and neck department, a very cool and vibrant department that we're proud to be on. That's it. So, as a quick background, we all know that thyroid cancer has seen a remarkable increase in terms of incidence, in terms of diagnosis, in terms of diagnosing both fortuitously, but also diagnosing through new imaging technology and all. It has seen a huge increase, talking 500% increase since the 70s. Probably one of the most common thyroid cancers right now in the developed world, and the most common cancer in North American young population between the age of 16 and 33, and probably going to be the fourth most common cancer by 2030. Thyroid cancer develops from different lines, whether we're talking about follicular-derived thyroid cancer or parafollicular C cells, where we're talking about medullary thyroid cancer. The distribution is pretty heavily based on, of course, papillary thyroid cancer and follicular thyroid cancer, and then you have the more rare subtypes such as anaplastic and medullary thyroid cancer. The more rare ones also happen to be the more aggressive, as a lot of you know. Now, thyroid cancer in itself, bless you, comes in different shapes and sizes. Some patients will look like this. Some patients will have a mass that is evident, and some patients will have a very, very large mass, right? But everyone's thyroid cancer will present in a different way, one way or another. I know a lot of people say, oh, it's the same thing, but every patient is unique, and every presentation of thyroid cancer is going to be unique. Neoadjuvant therapy, actually, one more question before I go there. What does neoadjuvant therapy, what exactly is it? So let's see what you have to say about this one. So is it a form of systemic therapy for locally advanced cancer? Is it neoadjuvant? Does that mean recent new FDA-approved drugs for cancer? Or is it cancer therapy as a primary treatment with curative intent? Correct. This is a form of systemic therapy for locally advanced cancer. So what does neoadjuvant mean? So neo, a Greek root, which means new, adjuvant, Latin root for assistant. Now, a lot of people hear about adjuvant therapy, right? We hear about cancer therapy. Someone has a cancer diagnosis, they get a treatment, a surgical treatment, and then they go ahead and have adjuvant therapy. Adjuvant therapy and assistant therapy, usually in the form of radiation or some chemoradiation. But neoadjuvant is actually the concept of giving it prior to primary treatment. Some may argue we shouldn't be calling it neoadjuvant. We should probably call it proto-adjuvant, right? You're giving it at first because it's not really a new treatment. You're giving it before. But that never flew with the medical oncology world. So it's still neoadjuvant therapy. So neoadjuvant therapy, like I said, treatment given prior to a primary cancer treatment. And in the thyroid world, primary cancer treatment is usually surgery. So you go ahead and give it prior to surgery. It is not a treatment for curative intent. That is something that people need to understand. And it is not a primary cancer treatment. The goal of neoadjuvant therapy is to downstage the tumor, decrease the morbidity and the toxicity associated with surgical resection, You want to improve the surgical outcomes and increase your chances of having an R0 or an R1 resection. And finally, you want to, as much as possible, try to preserve vital organs, vital structures, and their function. Surgical resectability. This is one of the key things as a surgeon that I'm looking for when I'm seeing a patient for the first time and discussing surgical options. So an R0 resection, as you can sometimes hear about it, whether you're reading your op report or whether you're reading reports about how they're discussing your case in a tumor conference, an R0 resection, as you can imagine, means you've removed everything. You feel like macroscopically everything is gone, and microscopically. R1 resection, you're probably going to have some microscopic disease left behind, whether it is on, you're considering that something was left on a nerve or on a structure that you didn't want to sacrifice and it was left there on purpose. Or sometimes you can remove all you can. They're going to tell you your margins are probably close. That sometimes means that you're probably going to be microscopic in R1 resection. And then R2, unfortunately, you're literally leaving tumor behind purposely. The definition of something unresectable, usually someone who is getting an R2 resection if they go in for surgery. So you don't want to do that, right? You don't want to go in for surgery if you're not able to offer an R1 or an R0 resection. If you're going in for an R2 resection, you may actually be causing more damage than good. And finally, it's a very strict definition. Theoretically, an unresectable thyroid cancer, for example, is one that's encasing the carotid, right? Or something that is involving the prevertebral fascia, so that sitting right behind your trachea and your thyroid, pretty much where your spine sits, if you're entering that fascia, that is going to be an area that is considered unresectable because you can remove all you want, you're probably going to end up having positive margins. And once again, the resectability, some tumors, you can be meaningfully resectable. So yes, you can actually meaningfully resect the tumor, but what are you actually causing in terms of morbidity? So for anaplastic thyroid cancer, 5% of patients are actually going to be surgically resectable upfront. That's very low, right? So if we're able to take that 5% and make it 50%, that's a huge win, right? So if we're able to do that with something like neoadjuvant therapy, that's incredible. When it comes to differentiated thyroid cancer or medullary thyroid cancer, usually it's upfront surgery, majority of the time, right? But you do have about 10% of cases, maybe 5 to 10%, that are not resectable upfront. So can we take that 5 and 10% and improve it with neoadjuvant? Your margin of improvement is not that big, right? In terms of anaplastic, if you go from 5 to 50, even if you go from 5 to 30, that's a huge jump. But in the differentiated medullary world, you don't have that big margin. So it would take thousands and thousands of patients, for example, to just look at imaging and see if you're going to respond. So we're looking at resectability and how will we measure the success of a neoadjuvant therapy? Well, it's literally going to be on the surgical morbidity. So to be able, and before I dive more into what we have in terms of neoadjuvant therapy availabilities and the different drugs, I'll look at how we measure it on the surgical side. So as a surgeon, when we look at the imaging, we look at the labs, of course, and we look at how things have progressed over time. We speak to a patient and we tell them, I think if I go in right now, this, and this structure are very much at risk, or I can end up causing this kind of potential defect. If I give you neoadjuvant therapy, I'm hoping to be able to, remove this risk. And how do you measure it? You can't really measure it through imaging because even if you have a regression, you may still have tumors sitting at that very high risk area. So we measure it by looking at the actual surgical morbidity. So once the surgery has been done, we give it a score, but then we also look at the score that we had given prior to giving the neoadjuvant therapy. So this score is in the works right now and trying to develop it. And the advantage of being able to do a surgical morbidity score is that, again, you'll measure the end point of your surgical, of the surgery that you've done. But the only disadvantage, again, is there's no perfect scoring system, but it is as close as we can get in terms of being able to measure the benefit of the neoadjuvant world. So the score itself, it's not too complex for the surgeon's world. You need to keep things simple for surgeons. And it's not too simplistic at the same time. There are going to be some key factors that need to be clarified. So you need to have certain experience, certain volume in these kind of complex cases to be able to do this kind of scoring. So this is what the scoring looks like that we're using right now. It's called the triple M score, or the MMM score, because it was developed between Mass General, Memorial Sloan Kettering, and MD Anderson. And the idea of this score is to be able to predict how will a patient do after major surgery. So when someone's coming with very advanced surgery, whether it's differentiated medullary or anaplastic, you look at them and instead of just saying, this is very high risk, well, we can actually score and give a numerical value, let's say, that will make sense both to other surgeons. So for example, this patient's coming in from another institution and they want to go ahead with surgery, but then you see it and you're like, look, if I look at the different scoring system, this is what you're at risk at in terms of development. I would maybe start with something neoadjuvant to shrink things down. The key things that we look at, of course, are how extensive is it? So the mild, of course, someone who comes in with a small little tumor sitting in the thyroid, you wouldn't expect them to have a high score. So most likely it's going to be a 0. Then if you move into the next score, which is a moderate, it's mostly gross extrathyroidal extension, gross extranodal extension. Severe, already high risk of being able to get a unilateral vocal cord paralysis. Maybe the trach is slightly involved. You may need to do a tracheal resection, bring things together again by 1 or 2 rings. If you have significant superior mediastinal extension, it's going deep into the chest. That's high risk, partial sternotomy possibility. And then, of course, it gets higher and higher. Very severe patient may need a trach or some big laryngopharyngeal excision. And finally, of course, the worst one of all being unresectable. So using this kind of overall score going from 0 to 4, when you give neoadjuvant therapy, so here you're actually seeing some inside data from some clinical trials that are ongoing where we're measuring this. So these are clinical trials where you're getting neoadjuvant therapy either in the ATC world, in the medullary world, or actually not just medullary, but RET fusion or RET mutated disease. You can see that the benefit of having such a score is that it allows us to see, look at how many patients were unresectable, and at least they became resectable. Yes, it was still severe, but they became resectable. And then how many people were in the very severe, and went into moderate and mild. So that's what we're kind of trying to get here. And when you're having a mean, I don't think there's a pointer on this, but if you're actually getting a mean score of a decrease of 2 or 1.5 on a score of 4, that's quite significant, not only for the surgeon doing it, but also for the patient. So I'll give you a more visual example here. This is a patient who had, this is an anaplastic thyroid cancer, very clearly unresectable, right? This is a number, this is a score of a 4. You can see what's pointing there with that yellow arrow. That's actually the carotid, completely encased, 360 all around, right? Great. So as you can see, this is an anaplastic thyroid cancer case. You have that arrow pointing at the carotid, completely encased with tumor, right? The patient received neoadjuvant therapy for 3 months and now became completely resectable. Actually, the score was pretty much a 0, right? So this is an incredible response. And then not only is it widely beneficial for the patient, but it's also helping us by having these scores. We're going to be able to then study this, get a better understanding, and then hopefully that this kind of scoring system is going to be then utilized not only by our 3 institutions that are working on this score, but hopefully around the world. So right now, this scoring system is in the middle of its validation. It's still not validated. We've used it. There's been some publications of it for a couple of projects and a couple of papers that you can find in thyroid or in head and neck. But right now, there are 6 of us working on validating this, and hopefully within the next 6 months to 8 months, this will be out and fully validated, and it can be used by anyone. And I think this is an excellent tool in the neoadjuvant world because if you're seeing your surgeon anywhere in the world and they have this score, you can then communicate with another surgeon, get a second opinion, and see, do you agree with this validation score? Yes, no, and would you go ahead with the surgery? Yes or no. Start with differentiated thyroid cancer, actually. And I'll pretty much start with the ones that get the least amount of response with neoadjuvant therapy to the ones that get the most drastic response. So differentiated thyroid cancer, and here we're talking about papillary, oncocytic, follicular, and all the variants of papillary as well that fall under there, oncocytic, Hürthle. So you do have a favorable response, but it's not as drastic. You should get a gene mutation at a panel prior to starting any sort of neoadjuvant therapy. It's not standard of care for advanced disease, and I put the yet there because we are working towards that with clinical trials right now, trying to show that neoadjuvant therapy for some very aggressive disease can actually be very beneficial for these patients. And I always recommend that you do have very close monitoring. If ever you are to get on a neoadjuvant therapy for differentiated thyroid cancer, because the response is not as drastic, oftentimes patients will stay on it for a while. And if it doesn't respond, the way I do it, for example, is when a patient comes in and I place them on neoadjuvant therapy for an advanced thyroid cancer, I pretty much tell them every time you're coming back in your 3 or 4 or 6 month follow up, I'm booking you for surgery. And if you come and your scans look good and things look stable, we'll just cancel. Much easier to cancel a surgery than to have to rebook one quickly because things have progressed and you're not responding to neoadjuvant therapy. So this is what I would recommend in terms of if you're going to do it for differentiated thyroid cancer, you need to have a very close monitor and a surgical plan pretty much at every follow-up. So how do we choose which neoadjuvant therapy to give for differentiated thyroid cancer? The way we look at differentiated thyroid cancer, of course, we look at it genetic and mutation based. So you have your fusions, right? So you have RET fusion, you have NTRK fusion, and ALK fusions. It's not very common in these cancers, but we do have targetable drugs for these cancers. So when you have a cancer that presents with this aggressive disease, locally aggressive disease, you can potentially give this type of medication and get a shrinkage prior to going for surgery. You have the patients, a large majority that will have a BRAF mutation in the differentiated thyroid cancer world. Very well-known drugs, of course, BRAF/MEK inhibition drugs, usually in combination, right? Either dabrafenib trametinib, as we hear, or vemurafenib with cobimetinib. And then you have the patients that don't necessarily, may not have these mutations, or even if they do, you still have the option of lenvatinib. So there are patients that can have an agnostic mutation panel, right? They've never actually gotten a genetic test, but they could still go on a drug such as lenvatinib to get a shrinkage of tumor. And this is an example of a BRAF mutated patient with differentiated thyroid cancer. And even though it looks very impressive and you think, this looks a bit more aggressive, maybe this is anaplastic, multiple biopsies were made and confirmed that there was no real aggressive, in terms of histological aspect to this tumor. But it was very aggressive in terms of its location. So as you can see, this tumor is primarily actually the metastasis to the lymph node that was severe. It is very large. It's involving into the sternocleidomastoid muscle up here that we see up there. Is there a pointer on this? No. Then if you look at the right-hand image, you can see that the tumor, that vessel that's kind of sitting right over here, okay, this is your subclavian vein going into directly into your superior vena cava here, going down into your heart directly. And this junction here is sitting right at the level of pretty much the communication of your neck to your chest. Any complication in there, you can have a massive bleed intraoperatively. It could be very complicated, needs a rapid opening of the chest, and could be quite detrimental. So looking at that, you tell yourself, is there any way I could shrink this to, one, make it a less morbid surgery, and two, decrease the risks of complications for these patients intraoperatively? And this is what we did. The patient had a BRAF mutation, and we put them on therapy, and this is approximately 3 months of therapy. And you can already see a very nice, it peeled off of the carotid artery right here. So it's completely peeled off, as you can see over here. It's peeled off of the larynx. It's nicely getting off of the sternocleidomastoid muscle, which is right over here, right? And that's just the axial view. If you look at the coronal view over here, this is where it was before, very high risk right here in that junction here between the jugular vein and the subclavian vein. And here may not look too much, but just in sheer size and how it's peeled off, this here is more than enough for us after to feel more comfortable to secure the vessels. And it had kind of moved upwards. So again, very beneficial. And the patient ended up having a much more straightforward surgery and post-op recovery. This is a clinical trial that is ongoing right now. It is almost complete in terms of enrollment. This is run out of Mass Pioneer, with Greg Randolph, with multiple sites collaborating, including here in Houston. And this is actually giving lenvatinib for any mutation for patients with differentiated thyroid cancer. So you give them lenvatinib up front, and then you go ahead and go for surgery. You can only enroll in this if you've actually have a resectable tumor, but you think that the morbidity may be too severe, so you want to go ahead with a neoadjuvant therapy to hopefully shrink it. There's another trial that's coming out shortly, which is going to be using a new drug by Exelixis, XL092. This is a new generation TKI, which is going to be once again used for the purpose of shrinking down the tumor to then go ahead and do a more meaningful resection. So overall, neoadjuvant therapy for advanced differentiated thyroid cancer, look for look for fusions, look for mutations. The response, like I said, is not going to be as drastic as you can see. I mean, it was a nice response for this patient I showed you, but it's not going to be the drastic one that you'll see with potentially with medullary or with anaplastic. But it's still something I would definitely consider in this population. The response sometimes is equivocal to the aggressiveness. So if it grew very quickly, usually they will also respond very quickly. But then you sometimes have to think, is this not actually, could it maybe not necessarily just be only differentiated? Maybe there's some anaplastic component to it. And of course, like I mentioned quickly, the multi-site phase 2 lenvatinib trial that is ongoing, almost done. And then the next one that's going to be opening up is this new XL092 phase 2 trial. All right, let's move to medullary thyroid cancer. So we all know about the FDA-approved drugs selpercatinib and pralsetinib. Pralsetinib has lost its FDA approval recently. So selpercatinib is kind of our main go-to when it comes to treatment for medullary thyroid cancer, especially advanced medullary thyroid cancer. And we did look into patients, and this is a lot of studies that have been done in collaboration with our institution here and Dr. Who, that a lot of you know. And they demonstrated this wonderful response in patients that received this drug when they were RET-specific inhibitors. So we thought to ourselves, should we be using these RET-specific drugs in a neoadjuvant setting? Once again, can we decrease the morbidity of the surgery, decrease the complexity of the surgery, and hopefully improve patient outcomes? And this was a small case series that was done where we demonstrated that patients had a massive response on their RECIST score. So this is a score that we use looking at imaging. So how much of a response had they have on their imaging? How much of a decrease in terms of tumor volume, right? So 50%, 30%. I would say the majority of patients sit around that 25 to 30%, which is a very decent response for volume change. We also saw massive decrease in terms of calcitonin, right? From prior to starting the RET inhibitor to right before their surgery. And CEA values that also drastically drop. So there's definitely a response not only on the imaging side, but also on the biochemical side. And here are some patients that had, these are images of the patients. So you see it says pre-neoadjuvant and post-neoadjuvant, and for 4 different patients. And you can see the huge response, even just on imaging, that allowed us to have a better and more straightforward surgery for these patients. So with that in mind, once that was developed, of course, a clinical trial was then, a formal clinical trial was developed, led by Dr. Zaferi Cabanillas, and who as the principal co-PIs here. And the idea was to use all RET fusion. Now, of course, it's more commonly seen in medullary, but even papillary thyroid cancers with RET fusion were included here, especially the young population. This study is going very well. Accrual is right now, I think, if I'm not mistaken, about 26, 27 out of the 30. So you would expect very soon to have the data come out from this, which I believe will be very favorable. So if you, again, I'm showing this that I showed before, just this drastic drop in terms of the score. I know it's not a validated score, we're working on it, but for the surgeon to be able to see this, to go from unresectable even to moderate, or from severe to mild, that's a huge win for the surgeon, of course, and specifically for the patients. There isn't anything else really right now for medullary thyroid cancer in the neoadjuvant world. This is what we have. This is, the best that we have right now. We are actively working on some new drugs in the translational world, on the mouse models and everything that we're working on. There are multiple teams around the world that are using them, that are studying this right now, but nothing right now in the pipeline other than the selpercatinib that we have. But we've been very fortunate with selpercatinib and how good of a response we've seen. Now we'll move into the ATC world. So neoadjuvant for ATC, of course, has shown the strongest data, especially in the BRAF mutated ATC patients. And to the point where we even recommend, if you have a BRAF mutated anaplastic thyroid cancer, no question about it, you have to start with neoadjuvant therapy, unless, of course, you're dealing with a tiny tumor, which is very, very rare. But in the usual situation, you should go on some form of neoadjuvant therapy, control, shrink, and then go for a surgery. For non-BRAF mutated patients, there is the option of lenvatinib and pembrolizumab as a combination. And for the BRAF mutated, of course, it's not just BRAF-directed therapy, dabrafenib, but also with pembrolizumab. For the non-BRAF mutated patients, we recommend lenvatinib and pembrolizumab as a neoadjuvant option. The only issue is lenvatinib is very high risk in terms of fistula and bleeding. It's a VEGF inhibitor, so patients that have locally aggressive disease sometimes cannot go on this kind of drug because it could lead to fistula creation. If it's encasing the carotid, it can be very dangerous. So other options need to be considered, but if not, this is usually what we'll go for. It is still unknown if patients should remain on drug after the surgery and for how long, because we have patients that get on neoadjuvant therapy, they have a remarkable response, we do the surgery, and the question is, should we go back on if we don't see anything? But this is active work right now that we're doing in a multi-center trials. So this is some data that we published last year from our group here at MD Anderson, where we had patients with unresectable, mostly either unresectable or very severe disease. And if you can see these plots here, it's remarkable to see how many dropped into the mild for anaplastic, right? This is a very clear example there, pre to post BRAF. I'll give you another example here. This is a patient who came with BRAF mutated anaplastic thyroid cancer, and after 3 months of dabrafenib trametinib, we couldn't see anything on the PET scan anymore, right? Some may even ask, what do you do for surgery? Where do you go? This is another case here, very aggressive disease going into the strap muscles, advancing locally aggressive in multiple ways. This kind of patient, if showed up, if you were to even talk about surgery, you're talking about a total laryngopharyngectomy, possible, tracheal resection and flaps and all, and the healing would be horrific. 3 months later, the patient was able, the patient already had a trach in because they couldn't breathe, but 3 months later, this is what they have in terms of disease, a very straightforward surgery after that. So the question sometimes I do get from patients, and it's incredible to think that we are even there right now where patients come in with anaplastic thyroid cancer, and we even get to the point where they then ask, should I even get surgery? I've had such an amazing response, which is incredible. So this is a patient who came in on the PET scan. You can see on the left-hand side, very bright, involving the entire posterior trachea into the esophagus, barely could swallow anything. This patient needed tracheoesophageal resection at the very least. After therapy was done, we ended up offering the patient a simple lobectomy. Because the other side was completely normal and the patient was not going to get radioactive iodine. So they could also just get a lobectomy. And this is an example. This is the same patient. You can see that what's left of the tumor is just a small little ball of calcification. It was a complete response. This is another case here of successful neoadjuvant immunotherapy and targeted therapy. Should we even consider surgery after? Once again, another remarkable response. The answer is yes. I would still recommend surgery. We still don't know the long-term aspects of a complete response on the clinical aspect in terms of imaging. Will there be another mutation? Will there be something that bypasses the drug and the treatment that you've given? We still don't know that. So for the time being, we all still recommend some form of surgery to go and remove the sites of prior disease. Let's see what time it is. How am I doing? Okay. So if I try to summarize a bit the evolving role of targeted therapy and immunotherapy, I guess, in surgery for aggressive thyroid cancer in the neoadjuvant setting, for differentiated thyroid cancer, um, the response is modest. Like I said, it's probably proportionate to the growth rate. Um, it is a good strategy for patients if you want to delay surgery or sometimes if you want to try to mitigate certain possible complications. I mentioned the lenvatinib and the XL092 trials. For MTC, right now, RET-specific therapy is what we have, and it has shown good responses in our clinical trials. Hopefully we'll have some new drugs to test in the near future. For anaplastic thyroid cancer, one of the strongest responses, especially for BRAF mutated. The question is, what do we do for the non-BRAF mutated, especially the ones that cannot be on lenvatinib? I would stay tuned because there's some very interesting drugs coming out for this patient population from all the translational work we're doing. That's what I had for you all. Thank you. Thank you for your attention. I hope I clarified a bit more about the concept of neoadjuvant, why we want to do it, and how we utilize it, especially as surgeons.